I would like to introduce Natasha, who's a professor of ophthalmology from Amrita Institute of Medical Science and Research Center, Kochi. And she's going to talk on another interesting topic, common mistakes in uveitis management. On to you, Natasha.
Good evening to all. Small change. I've actually resigned from Amrita and I'm at
Oh,
Chaitanya
sorry.
Institute now and visiting
Oh, sorry.
consultant at
Sorry.
a few other hospitals. But of course, that's very recent, so that's fine. My talk on mistakes in uveitis management can be divided into three parts: mistakes in diagnosis, mistakes in management, and complications due to the management. So where can we go wrong? Some of these mistakes are, of course, made by me, and some of them I've been learning from others' mistakes. So simple mistakes in diagnosis, we'll just go through it quickly. Just that, once we see the evidence of anterior uveitis, sometimes you miss it. The patient comes with pain, redness, photophobia, and even now, even in this day and age, there are people who send off the patient with some drops without doing proper slit lamp examination and missing the keratic precipitates and the cells and flare. So that is a simple mistake that can happen only when the patient comes back with severe redness and pain. Then actually the patient is put on the slit lamp. The other big thing to do is the failure to see the whole picture. For the example, this patient was being treated as chronic uveitis for quite some time, and nobody has bothered to look at that scleral nodules that were there. Patient was strongly TB positive, and ATT and all of those nodules resolved. The third mistake that often uveitis, once they see the uveitis, the anterior uveitis, they do not do a dilated fundus examination and just treat it as an anterior uveitis. An anterior uveitis is never an anterior uveitis unless you have ruled out that there is no intermediate or posterior involvement. And all the things that we can miss, like a cystoid macular edema, your vitritis, posterior uveitis, a lesion there, or a panuveitis with some vasculitis, all of this can be missed if you do not do the dilated fundus examination, and preferably at the first visit itself. Optic neuritis you can miss, and fundus examination often gives you clues to the etiology. That also you can miss if you do not do it, like the inflammation next to the scar telling you that it is toxo, the tubercles that tell you that you're dealing with TB, the candle wax drippings that tell you that it's probably sarcoid. For example, this patient, 65-year-old man, has been treated as intermediate uveitis with systemic steroids from outside. Worsening was there, and then he came to us. And the typical ARN was there in the periphery, which was completely missed because the person who was treating did not bother to look at the periphery to see those tongue-shaped patches that clearly give away the diagnosis of ARN. And the patient, of course, improved with antiviral therapy. So that is a common mistake, failure to do dilated indirect ophthalmoscopy to look at the periphery. Then, of course, missing masquerade. So especially with children, when they present with something that looks like uveitis, you have to absolutely confirm that it is uveitis itself that you're dealing with and not conditions like retinoblastoma or any other tumor deposits in the anterior segment. Now, going on to mistakes in management, this is a 40-year-old lady who presented to us with decrease in vision, and on examination, multiple sensory neural detachment, mild disc edema, and the FA was fairly typical of VKH with the pinpoint leakages and the bullous sensory neural detachments on OCT. But after we started her on steroids, 2 weeks later, she presented to us with severe ocular inflammation, orbital inflammation, and new lesions that appeared in her fundus, and then turned out to be manto positive strongly, and PCR of the aqueous we did, and it turned out to be TB positive. So failure to do routine investigations, though I think there's a recent publication that say that there is no increased risk of systemic TB when if you are putting the patient on steroids, and you don't have to always do it. But this is our experience that you cannot not rule out TB. And so you have to do your routine investigations before you start systemic immunosuppression or steroids, because in our country, it kind of so ubiquitous, it can coexist with everything. This patient was a 50-year-old lady, pain, redness, and defective vision, presented with exudative retinal detachment that continued to progress in spite of steroids. We had done routine investigations, but then still not responding to immunosuppression or steroids. And more investigations, we realized that she has scleral thinning and she turned out to be ANCA positive. So you have to think out of the box when you're not having a response, and a rheumatologist and a physician's help is invaluable in the investigations. This patient, a 48-year-old female, she had two pathologies. So she has an adenocarcinoma of the lung, and she's also having TB. That is, let me see. Yeah, she had evidence of TB spine at the same time with bilateral psoas abscess. So here we have two pathologies in the same patient, and the patient presents to us with a large choroidal granuloma-like mass with disc edema and fluid around it. And so we were confused as to, are we dealing with METs or are we dealing with TB? And ultrasound B scan again just did not give us any typical picture. And because finally we decided to take a tissue diagnosis, and a 25 gauge vitrectomy was done, and the patient turned out to be exciton positive for tuberculosis. And just by ATT alone, her lesion reduced and completely flattened and resolved. So when in doubt, a tissue diagnosis can solve many dilemmas. It can be an AC tap, or it can be a vitreous tap, or a vitrectomy and biopsy. Now, another patient, VKH, treated with steroids and azathioprine, developed fever and malaise and turned out to have agranulocytosis secondary to the immunosuppression. So, failure to recognize side effects of the medications that you're giving is also one of the mistakes that we do without proper follow-up of these patients, and seeing the systemic side effects also. And just looking at the eye alone is a mistake that a uveitis specialist cannot afford to do. And this patient was a VKH patient, but completely resolved and was on immunosuppression when they developed a small lesion at the fovea. So here, our FA revealed that it is a CNV. So again, in an inexperienced person, you will think that it is a recurrence of the VKH, but you have to recognize complications that can occur due to the disease itself which is unrelated to the original pathology, and is not a recurrence of the original pathology. And this was CNVM treated with intravitreal anti-VEGFs, and it completely resolved after 3 intravitreal anti-VEGFs. So vigilant for recurrence, recognize complications, recognize new and unrelated disease. This patient is a surprise. 32-year-old male presented to us with defective vision and floaters with minimal AC cells. There was a small vasculitis in the temporal periphery, but we couldn't really see anything else. And we sent for the routine investigations, came back 2 days later with pain and redness in that eye. And there was a surprise in the anterior chamber. It was a worm that, when removed, was a gnathostoma spinocerebrum. And so in uveitis practice, I find that you will, even though you ticked all the boxes, you can still end up getting surprised. So do's and don'ts: confirm you're dealing with anterior uveitis alone. Confirm that posterior segment complications of the anterior uveitis are not there. Simple acute anterior uveitis, you do your basic investigations. Other investigations should be tailored according to the history and findings. Then in your chronic anterior uveitis that needs more than 3 times a day for more than 3 months, you should be giving the patient systemic therapy. Uveitis in children needs thorough workup. Posterior segment complications will need systemic treatment, and don't start systemic steroids in inadequate doses, and don't keep patients on topicals alone if the patient has posterior segment involvement. In conclusion, a thorough and meticulous history taking, complete eye examination, investigating sensibly and ruling out infective pathology, seeking a rheumatology or physician's help when required, and treating adequately and follow closely is your key to a good uveitis outcome. But you should always be prepared to be surprised. Thanking you for
Yes,
this
yes.
opportunity.
That was again a wonderful talk.
This is all the things I could cover in so much time.
No. That was
Thank you.
again a very wonderful talk and very nicely completed this amazing session. So I think we have time somehow, due to some reason, speakers could not join in. Ashray, could you take some question?
Ma'am, thank you for this wonderful talk. You also mentioned about the immunosuppression. So after 3 months, like it depends on the pathology as well. For VKH, what is your protocol for maintaining immunosuppression? And how long would you keep the patient, and to what level you go, which line of immunosuppression?
I think in every uveitis discourse, we have this discussion as to how long should we keep the patient on immunosuppression. And although the Western world seems to kind of stop it at 6 months, 3 to 6 months is what they say. But I find that in our practice, definitely BKH requires more than 1 year of immunosuppression, most of the time 2 years at least. And I usually start the taper only after 1 year if I find it completely in remission and has not come back at all. And then I keep them on maintenance for the next 6 months and then slowly taper it. Usually about 1.5 to 2 years.
Remember, would you use biologics preferably in any condition, or
we are increasingly moving towards using biologics in pediatric uveitis because we have very good results with adalimumab, and especially if it is started early before the sequelae set in. And so with our pediatric rheumatologists, we have a series of cases that have those who have been started originally on adalimumab itself and those who have been switched over because methotrexate plus MMF and still recurrences are occurring. We are finding very good results. So in pediatric uveitis, I would certainly prefer biologics.
Anything to add, Dr. Rima?
Yeah, so pediatric, sight-threatening, and now the recommendations in the Euler recommendation, Behçet's disease, the combination of azathioprine and cyclosporin is the first line. But now the recommendation is you can start with the biologics in very severe sight-threatening Behçet's uveitis as the first line therapy, because these are the patients who would need a very long immunosuppression. And as Natasha said, we give immunosuppression for 2 to 3 years for VKH patients and Behçet's patients.
Anything to add, Dr. Jatinder, in all these talks? Some take-home points? Dr.
I
Malik?
just enjoyed the entire show from a balcony seat. It was all the stars performing, and I was just sitting and enjoying thoroughly. I enjoyed all the talks. Thank you, everyone.
Dr.
I just had to share
Malika?
one case of red herring just to put my contribution in. And this was a case of very classic HLA-B27 related uveitis. And somehow one of our fellows advised for the routine investigation, which I usually don't do. And this patient came out to be VDRL and TPHA positive. So if you are encountering such a case, what would you do? Like, would you also treat syphilis, or would you consider this as a red herring, as what is the title of the session?
What were the eye findings? Only anti-D uveitis.
Was HLA-B27 also positive?
HLA-B27 positive, and even MRI was suggestive of ankylosing spondylitis.
So this is infection with autoimmune disease.
One thing to understand here is that we should not get too distracted by one positive test finding. We should continue the complete investigation that is relevant to a case, because this can often happen. You can have 2 or 3 findings, and then you have to see which one fits the diagnosis, clinical diagnosis most, and treat. So,
No, it's
Is
just
it the
like
presence
adding
of
to
a
what
syphilis?
Natasha. Yeah, just
Sorry,
adding
in
to
the
what
presence-
Natasha said, that she should be like, we should investigate for TB. After this case, actually, I thought like we should also investigate for syphilis as a routine for all
actually,
uveitis.
yeah, I agree. Any case
Not
that we
related
see,
to uveitis though, but it just came positive, and both the things came positive, and patient also gave history of promiscuity later on.
see, whenever we see
So can I-
a patient of uveitis, I think it's better to investigate with everything. We need not, with everything, I mean, at least the basic panel, which includes syphilis, HIV, everything. Because, later on, it's too late. We would have spent a lot of valuable time before we reach that diagnosis.
Yeah. So if I can just add, so uniformly for every patient who presents to our uveitis clinic, we do screen them for syphilis. It is such a great masquerade. So as a rule, every single patient of new treatment naive or a new patient of uveitis, every single one of them are definitely screened for syphilis in our clinic. And just one more red herring in uveitis, which can sometimes mimic a lot of these diseases which we discuss, are drug-induced uveitis. So that is another history that we should always take from our patients. What are the specific drugs that the patient is using when they present to us? We have had patients who had presented with angle closure glaucoma and a hypopyon uveitis or bilateral choroidal detachments, treated in lines of uveitis or treated in lines of angle closure, turned out to be topiramate induced uveitis. So a lot of sometimes rifabutin, another drug which is used sometimes in TB regimens, is known to cause a hypopyon uveitis. So one specific history which we should always be asking our patients to rule out any of these masquerades is also asking what are the drugs that the patient is using when they present to us, because that in itself can give a huge clue about any underlying pathology, and that will
the
totally change your
uveitis
life
plus
management.
uveitis plus scleritis that presented after zoledronate, or acute orbital and ocular inflammation.